Can you hear me now?
Yes.
Wow, super, super.
Thanks.
Finally, it's like a miracle now. Tell me please if you listening to, if you hear me much more better. I have a professional microphone now. Tell me.
Yeah, we are able to hear you.
Can you hear me? Let me check. Let me check, sorry. I will.
Next day, same with the.
Can you hear me?
Very next model. One is like
Can you hear me? Sorry.
Yes, yes.
Okay, so who is my who I have to talk with?
Right
Sir,
now,
this is Dr. Priyanka and Dr. TP Chaturvedi sir is here.
Okay.
Dr.
Thank you
Sudhir
so
Yadav
much.
sir.
Okay, thank you so much for your kind invitation. But please, before I start, I ask to everyone to mute everyone. If not, we cannot be able to be effective, right?
Yeah.
okay,
Because
sir.
I am listening everyone, okay?
Okay.
So when everyone is mute and when nobody can talk, we can start.
Dr.
Tell me what
Arpita,
we
please
can do.
continue.
Hello, everyone. Dr. Priyanka, I am audible.
Yeah, you are
yes.
audible.
Nice to
Okay,
meet
thank
you.
you, sir. Hello, everyone. A very warm and graceful good evening to all the delegates. Before starting the session, I have a very important announcement about our next webinar, which is held on 26th of September. The topic is glide path. Myself, please mute everyone. I continue. Okay, myself, Dr. Arpita Singh, Regional Head of MACS Gorakhpur branch. On behalf of our organization, we would like to welcome our chief guest of this evening, Dr. TP Chaturvedi sir, President of UP State, and thankful to you, sir, and happy Teachers' Day, sir. Welcome.
Thank you.
Okay. Now we welcome our very talented and session chairperson of this evening, Dr. Sudhir Yadav sir. Dr. Sudhir Yadav sir is graduated from SMSS Dental College, Aurangabad, and senior dental practitioner from Gurgaon, practicing for the past 12 years. Dr. Sudhir Yadav sir has pursued all the 4 courses by Dr. Paulo. He holds the position of director in Indian Academy of Digital Dentistry. Welcome you, sir. Now I would like to welcome our wonderful speaker, eminent speaker of this evening, Dr. Diego Lops. He is a teacher and tutor at the Department of Implantology, head professor in St. Paul Hospital, University of Milan, postgraduate master degree in advanced oral surgery and maxillary reconstructive technical, University of Paris.
Yes.
Teacher and tutor at postgraduate implant dentistry and prosthetic rehabilitation course, dental clinic, University in Italy. Winner of IIS International Prize for the best clinical research. Welcome you, sir. Dr. Diego Lops.
Thank you for your kind invitation. It's a pleasure for me to be invited in such interesting network. And just because I am transmitting my web speech from Damascus. I am from Italy, and so as you can see, it's quite different because it's quite difficult because I was given 3 days of lectures and courses, 24 hours a day. I'm transmitting from my room now in Damascus. I try to do my best for the setting, and I'm sorry for if the quality of the audio or the lights is not so like my standard could be, but I hope to compensate with the slides, and my speech is related to aesthetics on implants. Of course, is a complex case in anterior area is what I usually do, and we will shift in a point in an exact point of the case discussion. We shift by giving some additional recommendation related to Mallet, right? To the magnetic dynamic. So we shift the presentation and we go back to the presentation to tell the final story of this guy. Okay. So if you allow me to start with the presentation, to share the screen.
Sir, Dr. Liago Lops, sir.
Yeah.
So we want few minutes for welcoming our chief guest of this evening. So we want only few minutes for this. After that, you start the session.
Tell me when, and I will be ready.
Okay, sure, sir. I invite Dr. Priyanka Yadav that please come forward and welcome our chief guest of this evening, Dr. T.P. Chaturvedi, sir.
Thanks, Dr. Arpita. Thanks each and everyone for being with us today with this great session. I must say thanks to our course mentor, Dr. Diego Lops, for giving us this opportunity to learn something new on Teachers' Day. Thanks to Dr. T.P. Chaturvedi, sir, State President UPIDA, for giving us his time. And special thanks to Dr. Sudhir Yadav, sir, Chairperson of this session and moderator also. And thanks to all participants from India and other countries. Thanks you each and everyone. Now I request Dr. T.P. Chaturvedi, sir, to bless us with his few words.
Thank you, Dr. Priyanka. I am audible?
Yes, sir, you are.
Thank you. Thank you, Dr. Priyanka, for the nice program you have arranged. And I'd like to give thanks to Dr. Arpita Singh, who has nicely introduced our guest and started the program. Especially if you are doing in such a magnificent way, such type of program regularly, especially on the Teachers' Day. And Dr. Diego Lops, who is a very famous implantologist. So, sir, today's Teachers' Day in our country, 5th September is considered the Teachers' Day. And you are going to teach us about the implants, and that is every audience is obliged from your gesture that you are presenting. And thank you, Dr. Sudhir, who is chairing the session for this program. And especially if Dr. Priyanka like organizers is there, then she can manage anything. And especially he has created a miracle in webinars arranging in the UP State, India. Thank you, Dr. Hridesh, Dr. Deval Arora, Dr. Kapil, Dr. Rajkumar Singh, and all the office bearer and all the audience who has given me opportunity to be a chief guest. So I don't want to give some more time. And everybody is here to listen to Dr. Diego Lops. So I request Dr. Priyanka to start further and proceedings of the conference.
Thank you so much.
Thank you, making me a chief
sir,
guest.
for your kind words and presence. Now I request Dr. Sudhir Yadav, sir, to say a few words on Mallet.
Am I audible?
Yes, sir.
Yeah, thank you, Priyanka. So it's been 3 years I'm using magnetic mallet, and before that, for different kind of complex problems, I used to buy different products like piezo and sinus lift kits and so on. And after using in 2019, I was in Italy, and I was working with Claudio Di Gaglio and Dr. Cohen, and they show me this wonderful machine, and we used it on rabbit jaw. And believe me, rabbit jaws are very small, and we splitted that bone. And I really amused to see this kind of technology, and I immediately ordered for that. And since then, I'm using it. And I can say one word: it's a one-stop solution for all the complex problems. So I'm very satisfied with it, and rest I'll keep it for Dr. Diago sir, and he will explain the rest of the things.
Thank you so much, sir. Thank you, sir. Now we would like to welcome our course mentor, and I know everybody is waiting for him, Dr. Diago Lops, sir. Sir, please, you may continue the lecture. We all are waiting for you.
Okay. Let me share the screen. Is it possible?
Yeah.
Okay. Now I feel very relaxed by now. I have to tell you, because it was crazy to try to find. Okay, can you see the screen?
Yeah.
Yeah, okay. So before starting this page, I would like to tell that this kind of focus we are introducing today, magnetodynamic surgery, you could immediately think about to use this kind of device for teeth extraction, root extraction. Fantastic, fantastic, time saving, bone saving. Okay, but maybe many of you already saw something related to this kind of use. Okay, but I would like to focus my attention on the other side of the moon, related to other additional interesting use of this kind of technology, especially related to my practice that is focused on the treatment of anterior area. So GBR and implant placement mainly, okay? So I will show you a case, as I told you, that I treated and completed in a way. But what I would do tomorrow in my daily practice, maybe I will change two things, two procedure related to this case. I want to show you the case, and I will show you what I will do today instead of what I show you, okay? Just because of the magnetic mallet. Okay. So I am mainly related to the treatment of both the prosthetic issue and the soft tissue related to give to the emergence profile a natural appearance. But of course, we cannot, let me skip the audio. Okay, but of course, we cannot escape to give the surgery the right importance in order to give the emergence profile and the prosthodontist activity the right value and the right outcome. So we will talk about everything. Let me check. The story is the story. Sorry for the audio, because in a Congress, I can modulate the volume. In a web Congress is quite difficult to do. The story of this guy is a 22 years old guy without the lateral incisors. This guy arrived to my attention in my university department to treat this with 2 implants in the lateral area, is edentulism. But nobody told him that maybe he could afford for something more. This was the situation, the clinical aspect related not only the edentulism in a lateral incisors, but also the diastema after an orthodontic treatment. This is the situation. Can you recognize which kind of adhesions there are here and there are here? Maybe enough to put an implant, but not to have a perfect restoration of the convexity in anterior area, just like that. This is the feature of this guy. But we have to go back. We have to go back 1.5 years before. The real situation of this guy is not like I showed you before. It's like that. Take a look. This was a very sad guy. Take a look at these eyes. When I was 22 years, I was super happy of my life. Super. I cannot accept how sad are these eyes. And immediately, when I asked to him, okay, why you are always like that? He showed me the reason why. He was very tired of this situation. He was completing his orthodontic treatment, and finally he was approaching to the date to remove these orthodontic devices. After so many months of treatment, and an additional issue that you have to know, that this guy is from London. I am in Milan. He was treated in my university in Milan. So this is a situation before something that, in my opinion, could be performed in a predictable way only by means of VACs, in order to plan something that could be a mock-up to discuss with the patient about the final outcome, for example. And when we reached the position of the teeth, in order to be suitable and fitting with the VACs, we stopped the orthodontic treatment. We started from here, and we were like that. Okay, this was enough for us to start an implant placement, an implant treatment, right? So because the dimensions were respected in order to compensate with ceramic veneer in a central incisor and the canine, and puts the lateral, the implants in a lateral incisors. So this is when we find ready for the surgery this guy. Don't worry about the diastema, because the diastema was calculated because of the proportion between the canine, the lateral, and the central incisor. If you not believe me, let's wait. The case. Okay, this is my project. Everything was good. We did the surgery. I will split the surgery in left part and in the right part. I will skip the audio. Okay. Of course, we need to do a GBR procedure, addition to the implant treatment. 2 release and incision were performed, and in this area, there we found so much scar tissue that was a problem for us, and I will show you which kind of complication. But this is only to compensate with a cosmetic GBR, in our opinion, in our plan, this kind of edentulism, and associate a bone granule and a collagen membrane to the implant placement. As you can see, I don't mind absolutely if I need to create some adhesions related to the implant. In this case, take in mind what happened. Okay, this is a adhesions due to the fact that, that if I go palatal, of course, I risk to damage the buccal bone plate. It is a problem. It's not a very good problem, a real problem, because we need to do, of course, the GBR procedure. But maybe, for example, with the magnetic technology, maybe we could overpass this problem, because I will show you a case in which we will expand this kind of bone crest. This is not meaning that we don't need to do additional GBR. We need to do, of course, a GBR, because once you lose the tooth, the bone will be remodeled. So you need to restore the convexity with bone granules. Of course, there is no escape. But with the mallet, if I had to treat this patient tomorrow, probably I will change my device. Okay. This is the GBR. It's very simple, horizontal. And in this case, we selected a resorbable collagen membrane. And we didn't fix with some pin this kind of membrane, because of the stability of this membrane and the limited extension of this horizontal augmentation. But what if the augmentation should be massive? In that case, I need for sure to fix the membrane. As in the case with magnetic mallet, I will show you. Of course, we need to do that. So the contralateral area was treated just like that, just like the 1.2 tooth with the narrower implant, 2.8 millimeters, in order to save interproximal spaces, because the horizontal space in a 1.2 tooth was 0.7 millimeters more. Okay, that's why. But in all the cases, we use conometric implants with Morse type connection and a platform switching in order to save much more soft tissue we can. Everything is clear? Am I clear enough? Okay, I hope yes. I see a colleague, my colleague, they say yes. Okay, it's okay. You can see here a complication, a surgical complication, perforation of the flap. Absolutely expected to be, no problem. It could be easily managed, easily, because of the softness of the flap. Okay, just like that. I want to show you. Yes, and that's it. Till now is a very simple surgery, very predictable surgery. And here is the right side. This is the right side, just only to show you the right side for us is the left side for the patient, of course. And here you can see the drilling faces, very similar. The concept is absolutely the same. And in this case, you can see it could be preferable to save the bone instead of drilling it. That's why today, more probably, the magnetic mallet could be a very useful device for us in order to save that bone and stretch it and pull it and condensate and press it buccally. And I will show you a precise moment in which this kind could happen. Okay. So what happened 9 months post-op? But I want to because I want to spend some time for the magnetic mallet solution. Okay, here we are. I changed the presentation. Okay, what can I say about different option if compared to what I already shown? Well, I can spend time for something additional, but important, just like to use this kind of device for tooth extraction, because we can consider a new standard in the preparation, for example, of the implant bed, but new standard for example, how simple is our vision without any saline, for example, with this kind of cold surgery. So we can associate the strength and the precision in our action with our devices. We can link together. And we are talking about cold surgery and cold action of the device. No eating of the bone. There's no eating regeneration. And you know much more better than me what I mean. Is another additional value of this kind of technology. Every time, not every time, but that time you need. This could be very helpful. And it's very interesting. Take a look to this. How can this magnetodynamic technology may affect the bone loss? Of course, could be a bone saving. And I want to show you something very interesting. Take a look. with a cooperating university in Milan, and Dr. Motta is a very good friend of mine. That's what was created. We want to show that when you drill, take a look at the weight. Can you see? Okay. Can you see the number, the grams? Okay. This is the weight of the fragment of bone. You drill, of course, and this is the weight, 0.3 gram less. It means that when you drill, you remove bone. Of course, is that subtraction. Let's have a look with the preparation with magnetic mallet. Same weight, of course, because the bone is not removed, but is replaced. There is a condensation, laterally. Okay, this is very interesting. So you can reshape the 3D dimension of the edentulous site. Let's have a look to this. This is a post-extractive implant in which we need to create a new road for our fixture. If this kind of picture probably does not mean so much for you, I want to be more clear. Let's have a look. This is for the root, and what is? This is the new implant bed for our device, for our fixture. Pressed and created and condensated by the action, by the cold action of the mallet. So we have a new site for the implant, palatally shifted, perfectly shifted for the prosthesis with no bone loss, no preparation, no subtraction, no reduction of the bone. So we can have something precise and something predictable, both at the same. And this is very interesting and helpful for us. After, you can easily put the implant. So let's have a look to this. Okay, here we are in a edentulism in a 1.3, the canine area, and we have some problem also in a 1.4 site supported by implant, but we discovered during the surgery. In this case, we need a massive GPR, massive horizontal. And you can see this kind of flap is half split thickness because I want to create two different levels of flaps. One superficial with the mucosa and one in the inner part, deeper for the periosteum. And detach the muscle tension so that we can have a first membrane, natural membrane created by the periosteum, and that can provide for a more blood support if compared to a normal one. And the superficial membrane, the superficial covering that is represented after putting the membrane, the collagen membrane, by the superficial of split flap. Of course, this kind of flap is more, it requires more skill from the surgeon, is more demanding, is more time consuming, of course. But the outcome for us is amazing. I will show you. This is a detachment of the valve split. You need to be patient and don't stretch the flap. With this kind of split flap, if some scar tissue will be, you risk some damage, as I show you. And I want to show you another case, another example, and how to treat this kind of flap perforation. As anyone, doctors, everything is good, is clear. Okay, if I don't hear from you any reply, I can go on. You can easily see in this way, here, there will be some scar tissue. You risk, of course, some damage of the flap. Just like there. This is the moment in which we stretch the flap and damage it. But when you will see how soft is this kind of, just like that, this kind of, that is the moment in which we have the damage of the flap. So you need to resuture it and create and try to go on with the second. Okay, with the second one. Okay, this is the suturing when the flap was stretched. And we continue to create the natural inner internal membrane and detach the muscle. Some tension already occur. You need to stretch and detach from muscle until the flap is soft. But what is very interesting is what is going to be shown. Okay, this is the second barrier, because we need now a complete full thickness exposure of the bone, because we have to proceed with the GBR. This is the bone exposure, because we are ready for the implant placement and the GBR with, in this case, with some pins to fix the membrane. In this case, this kind of osseodensification, we don't want to lose any bone, and we would like to save a three-dimensional availability of the bone. Okay, this is the natural barrier to protect the future membrane, collagen membrane we will put. Okay. Now we refine the flap and we are ready with the mallet. We are ready to create the implant bed. As you can see, it's a very thin layer. So of course, we need to add the GBR procedure here. What happened? Okay. So, now I want to skip, sorry, I wanna skip the previous one. I want to skip the previous one because I want to show you the, okay. Okay, this is one I want to show. Okay, you can see now the amount of the thickness of this bone is 4 millimeters. Now we need to wait, maybe because of the computer is we need to wait. Okay, take a look. And if you take a look, I wanna stop myself. Sorry, I don't know what's happened, but it could happen. But it could happen. Sorry, I am in Syria now, and so it's quite difficult to, okay. This is the moment. Okay, maybe in this way it could be good. You can see in this way. Now, you can see here the stretching of the bone and the new convexity you can create with this kind of device. Is it right? This is the value. You can pass from the concave to the convex without a bone reduction. Okay, this is another important issue. Take a look. Convexity now. Complete saving of this buccal bone, and you are ready to put the implant. This is amazing because it's bone saving. Okay? Now, let's go Okay, when we put the implant, you can see easily that the bone buckling was not damaged. So we are ready for the GBR. Just because we need a great amount of horizontal augmentation, we need to fix the membrane. So let's count how many seconds does it take. 1, 2, 3, and that's it. 1, 2, 3, and that's it. Okay, let me stop now. Okay. If you are trained and usually do GBR with the pin fixation of the membrane, you, of course, know what I mean and what I'm referring to. It's very difficult in some part, in some area, and sometimes with a not straight bone, it's very difficult to fix easily this kind of pins. This video was real time. There's no trick. One try and one outcome. This is another important issue related to this tool, right? So, in my opinion, the additional tool that we are discussing today in the preparing the site and in the stabilize the membrane is a great value for us. It's a great value for us. So let's go back. Let's go back to the case. What happened 9 months after the surgery? This is the situation. It was crazy because 9 months after the surgery is not a normal time to restore something that I put with some implants that I put with a normal horizontal GBR, because usually it takes 3 months and that's it. So another risk is why this patient was left like that without anything. Why? Please stop talking, please. Stop talking, please. Stop talking, please. Okay. It was risky to leave this patient like that, but the reason was, and the problem was this, you can see too much large. Teeth came back distally. Was crazy for me, was crazy. Because of the lockdown is the answer. Because this patient should go under the provisional restoration 8 months after that surgery. It's weeks after that surgery. But COVID came to Italy, and not only. So that patient was blocked in UK and cannot afford my treatment for the prostate. And as soon as he came, teeth were not in the position we left. Was crazy for us, much more challenging. Okay, this is the situation. So this is what we can do in this situation, in this time. Okay, now let's see the end of the story. It's quite interesting. it's quite interesting because we had two roads to run. The first is to do again orthodontic treatment to replace the teeth where we want. But this road, our patient refused because he was tired. It was complete this treatment. And so I asked my dental technician, okay, just to follow is willing, because I understand a sad guy, a 22-year sad guys. So I asked my dental technician, okay, could we do the same respecting of our treatment plan in this situation? And he said, okay, we can do it. So let's proceed with the prosto. In this case, we plan to have our VACS as a guide, to create some mock-up, to create some template to guide our gingival reduction for the parabola of the adjacent teeth. And so we perform both in one appointment, the gingivectomy and the surgical re-entry. And we wanted to refine the soft tissue convexity with the adding, of course, not in this case, with a soft tissue graft from the palate, but with the matrix, because we want to reduce the morbidity for the patient, because this kind of addition was only cosmetic, right? I want to show you, of course. This is the re-entry. Okay, you can see, in this case, we need to pool buccally. We have to create an envelope in the 2.2 and in 1.2 area, and increase the convexity of this area with some matrix, some collagen matrix. In the same appointment, we use the templates to create the new gingival architecture for the adjacent teeth. After that, in the same appointment, we took the impression. In this case, analogic impression, not digital. Because as you can see, when the addition of a gingivectomy, so much blood, much more than we want to, is in that impression, the eventual digital impression. In this case, we were, for this reason, analogic. But it's very important that the digital part of the prosthetic reconstruction is planned by the dental technician digitally always, because by digital, the dental technician can create, according to the clinician, it can create very precisely in a 3D dimension the S line of the emergence profile of the implant supported restoration. This is the envelope we need to gently create. during the uncovering procedure, and that's it. So this is a template that can guide our blade in order to create the perfect representation of the wax up we plan and we create and the patient accepted. In this case, no bone was removed because this was only an overgrowth of the soft tissue of this gingival architecture. We only release the tooth shape. So we start trimming the membrane but before the membrane, sorry, the collagen matrix, so sorry. And try to pull it and fix it with the suture. In the meanwhile, we will provide for the P-cap placing. This is only cosmetic addition of convexity, right? Is not to increase the bone supporting. Okay, this is live. This is what we can do. Could you see how much we expanded the convexity? Okay, once we are happy for this kind of implant access, the difference in the peaks, in the pickup is due to the difference of diameter and the components, right? This patient is belonging to a protocol related to the comparison between the 3.4 millimeter with the 2.8 super narrow cone Morse retained implant. Now we are ready for the impression. Now I want to show you the gain of the buccal convexity. It's very promising for the definitive reconstruction. Now we ask for a provisional restoration to the dental technician, and when the provisional will be ready, the next appointment, we can take the definitive impression for both implants and teeth and veneer, because now we cannot take an impression of the veneer because of the bleeding, because of the surgery to release the teeth crowns. And the next appointment, we create the definitive impression and we put the provisional on the implants and we leave the patient go back home with the new provisional on teeth, thanks to the use of the mock-up as a template for the provisional. We are ready for taking impression. It's an open tray technique, of course. You can use a polyether or a last generation siliconic material, in this case something putty, because we need the consistency very tight and very precise, not soft material, because we need the position, perfect position of the implant, no stretching of the material that can cause a not precise impression. Okay. The pickup in the 2.2 is retained with a cone morse effect, so we don't need for an open tray technique, okay? So we are ready. Take a look to the back, to the occlusal aspect, like that. Okay, we are very satisfied of the buccal reconstructing of the convexity. So this is what we have. In the meanwhile, we were waiting for the provisional, but have a look to the new rebuilding of the buccal convexity. So we can shift the white aesthetics. The white aesthetics is related to the definitive impression. The patient was recalled for this. And this is the reference that we can achieve from the VACs in order to guide us in a 3-dimension in the removing of the excess of enamel, even this kind of prosthesis were minimally invasive. But if you can see, if we want to go in this area and in this area to cover and compensate this diastema, we need to go for sure in this area and in this area and reduce this kind of enamel in order to cover completely the mesial side of these two central incisors. After that, we can try the mock-up that will be the guide for our provisional. We take the impression, the putty and the light, consistent, remove the impression, everything was good for the dental technician that have to turn this kind of analogic impression into a digital. So we have the chance to choose analogic or digital for the clinical impression. But the dental technician is actually obliged, if you want to get the best outcome, or he is obliged to shift eventually from the analogic to digital. Because digitally, we can plan the emergence profile shape very precisely. This is not possible with a live normal mastercast. It's not possible. After that, after placing the provisional on implants, we can fill with resin the mock-up, and the provisional is provided for the patient. Now we have to wait the natural and the complete maturation of the peri-implant soft tissues. And the patient and the dental technician is ready to give us this S-line for our crown. And we know that the emergence profile has to follow some convex area for the emergence profile with us in a circular epithelium area, a concave area. That means that is the corresponding zone of the mucosal cone. This kind of not keratinized epithelium is depending by how much soft tissue we got buccally. The more soft tissue we have, the more concave this area will be. And after that, a straight area, more apical, that is depending, is this height, the height of this area is dependent, of course, by how much deep we go with our implant. Bone level, 1 millimeter, 2 millimeter below the crest. It depends by our implant, of course. So we need to respect this kind of rules in order to create a natural and predictable and stable peri-implant mucosal cone. Just like that, we need to respect this area. So we can reproduce this kind of mucosal cone shape for the prosthesis after we run an hard row with surgery. So if in the situation like this, in which in only one step, just directly, thanks to the provisional, everything is good, you are satisfied, okay, even if you go analogic or digital, you can tell the dental technician, okay, let's go on for the definitive. He has to turn the cast into digital, and I will show you how. And we have the definitive. Sometimes things are not so simple. Sometimes soft tissue will change their position. So in this case, you need to go for another additional impression. Analogic or digital is not important. The important is that our dental technician go digital. In this case, nothing happened. Nothing happened. So one step was enough to complete the case. But of course, we need an additional impression, not for the implants, but for the ceramic veneer. And if we have to take the impression for the ceramic veneer, of course, we need to give again an information to the dental technician about the implants, because he has to work in one single cast. This is how we can create the emergence profile, customize emergence profile, just like that. Only digitally we can do something like that. It's not possible to do with analogic. It's not possible. I want to show you. That's it. You can create some pushing or not pushing area just like that. I want to show you. Take a look. This is a customized area. You can model by digital, and even with the live chat with the dental technician, you can create the change of this. Can you see? The S line, the concavity, you can work on it. And when you're satisfied, okay, let's leave situation like that. So we provided for this kind of S-line reconstruction with the reprise of the convexity and respect the convexity we got with the surgery. Okay, this is the angulated abutment in order to compensate the implant access position if necessary. We use this in order to have the guarantee that we could go for a screw retain restoration. It's a very helpful tool for us, for the definitive, because allow us to go for a screw retain restoration quite always. And we know clearly which kind of advantages we have if we go for a screw retain restoration instead of the cemented. If we think about how simple is the referability and removal of the crown if some inflammation may occur. So let's go to the final step, the definitive. We are ready for our patient finally. And this is the compensation of the disaster due to the COVID. I don't know in India, but in Italy it was a disaster, really a disaster. Also for this guy, could be. Fortunately, I want to show you that was not like that. This is the day of the cementation of the veneer and the screwing of the implant supported restoration at baseline and after 6 months. Sorry, because I don't have more X-ray to share because it's a super fresh case, but I would like to share with you. And maybe in the next year, we can follow the course of this guy. But finally, it can smile like that. And if you do not remember the starting point situation, I can do for you. This is the placement of the crown. But what is a very promising and satisfying and is pay me back is the quality of these peri-implant soft tissues. Take a look how stable are this kind of soft tissues. And this is the final outcome. And if you do not remember the starting point, this is the starting point, and this is the end of the story of this guy in the COVID period. So, my friend, here we are, and I would like to thank you for your kind attention, and I want to leave you hoping to see you live with 3 recommendations in your dental practice. Even we are talking about mainly of this kind of magnetodynamic technology. The first recommendation is do things with passion. Be passionate. The second is be passionate, but the third one is still be passionate. This is what I would like to transmit to my patient every day in order to stimulate them to follow me in sometimes more demanding roads, but that can guarantee the patient the predictability of both the function and aesthetics too. Okay. This is I will let the wind quiet me. This is my reference. Do not hesitate to contact me if necessary. I'm happy to share with you my experience. And please, I hope to the time dedicated was respected. And please tell me what I have to do now. I am happy to answer to your question.
Thank you so much, sir, for your wonderful lecture. It's so informative also. And it's request to all our delegates that if you have any queries or doubts, then please share it in chat box.
Yeah, and I try to have a look to myself and I don't see myself. Oh, now I see myself.
Sir has already shared his Insta ID and email ID, so you can contact directly from sir also. Thank you, sir. So I think that it's a time to end the session, today's session.
Now we would request Dr. Sudhir Yadav, sir. Sir, how was the session?
It was an excellent session, and I could learn a lot of things in it. And I have one question, Dr. Diago, if you don't mind replying it.
Nice to hear from you.
Sir, when you have designed the smile, in the prosthetic part, have you used the analog technique or the digital technique?
Thanks for your question. In this case, we created some analogic boxes, but we immediately scan it and turn to digital in order to create from the beginning the exact emergence profile for the definitive and the shape of the mucosal cone, especially for the buccal side of and so we had some chance to know in advance which kind of position for our implants. Even we didn't go for a digital planning guided surgery, because my friend, as probably you know, I am sure that you know, digital and guided surgery not always is mandatory, not always should help us too much as analog. Sometimes it's absolutely necessary. For example, if you have to go in aesthetic area with a post-extractive, of course, the only way to go correctly from apical to coronal with the implant, it's only to go with guided, of course. But sometimes if you are quite skilled for a normal implant placement, even we have to go with the GBR, no additional cost for patients should be provided with an additional guided surgery. The answer was finally analogic at the beginning, discussing on it and turn it in digital, of course.
Okay, thank you.
Any other question? I guess no questions.
Oh, I am happy to hear this because it means that it means two things. It could be nobody understood anything, or everyone, or I was so clear. And of course, I am a fan of the second.
Thank you so much, Dr. Diago. It was a wonderful session. Hopefully everyone enjoyed a lot. And we wish to see you in India in future after the COVID. We would like to join your lecture live also. Thank you so much, sir. And thanks to our participants. Thanks to Dr. Sudhir Yadav, sir, Dr. T.P. Chaturvedi, sir, and especially Dr. Kapilgar, sir, and our all participants. Thank you so much. Dr. Bennett, he always continuously supports and attend our all webinars. Dr. Ajit, sir, he is also a DDS. Dr. Deval Arora from my team, Dr. Amit Singh, Dr. Utpal Chakravarti, Dr. Vikram Anand, Dr. Hidesh is from MACS team, Dr. Juhi Yadav ma'am, Amrita, Dr. Pramod Yadav sir, and Thidat, and Marina, Rupali Sharma, she is also from MACS abroad. Thanks each and everyone for giving us your time.
Thank you, Priyanka.
Thank you all. Thank you. Wish to see you all in our next session on 26 September. Thank you all.
Sure. Bye. Have a nice day.
Thank you, sir. And thanks to Dr. Rajkumar Singh, sir, our team leader, Dr. Arpita Singh, my colleague and my friend. Thank you, each and everyone.